Hi, my name's Jo Gibson. I'm a clinical physiotherapy specialist working at the Liverpool Upper Limb Unit in Liverpool in the UK, and I'm also a consultant in private practice. Now, we've had lots of shoulder offerings over the last few weeks talking about some really interesting case studies. We've talked about growth plate injuries, we've talked about AC joint injuries, we've talked about osteolysis. And so, what I was very aware about is I didn't talk an awful lot about rehabilitation. If we look at AC joint injuries, remember, we talked about osteolysis as a sequelae of somebody who might have had an instability injury if we load them too quickly. And we also talked about osteolysis if people do heavy weightlifting. And certainly, if your one repetition max is 1.5 times your body weight, and that's what you're doing regularly, then that in itself is a risk factor. So we talked about load and we talked about previous trauma. Now, I'm sure I also mentioned when we look at AC joint instability, which is probably one of the other most common AC joint pathologies we see, again, either direct or indirect mechanisms, either a fall onto a cross-adducted arm and onto the acromion, lifting it away, or an indirect mechanism, again, onto a fall onto an outstretched arm. Now, we have these classifications relative to the amount of damage that's done to the ligaments, but also the fascia that attaches to the AC joint. So we have a type 1, which is a sprain, a type 2, where we disrupt that AC joint capsule, a type 3, where we lose the AC joint capsule and the correlate ligaments, and then 4, 5, and 6 really depend on the amount of damage to the deltoid trapezial fascia and what direction the clavicle goes, whether it kind of goes up, back, or down. Now, that sounds great, and there's a general consensus that if it's a 4, 5, or 6, it needs surgery. If it's a 3, everybody argues, sees what happens with rehab and operates if people are still having symptoms. And a type 1 or 2 actually should be a rehab issue. But what we're seeing is if you look at X-ray and use that as your diagnostic or your grading or classification, then actually MRI and CT disagree with that in half of cases, either making it worse or less severe. But the thing that's really relevant with all these things and the increasing trend we're seeing in the literature is, as ever, the clinical presentation is the most important thing. So Len Funk, who's a surgeon who works near me, and we've done various things, lecturing together and writing stuff together, talks about copers and non-copers. And that's not, is the patient a coper or non-coper, but essentially, irrespective of what a scan's saying, clinically, have they got good movement? How badly are they affected? So the imaging is useful, but clinically, probably our examination is more useful in that decision making. And I've certainly had somebody recently diagnosed as a type 3 injury, theoretically needs 6 to 12 weeks, was back playing in 2 weeks. So again, it's weighing up those different things. But when we look at AC joint pathology, we see the instability, the osteolysis, and osteoarthritis. And again, you might remember I mentioned that what's really interesting in long-term follow-up studies of patients who've had instability injuries, just those type 1 or 2, actually there's a high prevalence that go on to develop osteoarthritis in the AC joint or have some ongoing niggly symptoms. Now, why is that? Do we have to just accept it's very vulnerable, or is it also the trend that generally patients are encouraged just to get back to what they're doing? There's some studies that follow patients up over time and show that a worsening of scapular dyskinesis, which is interesting if you followed these before, when we look at the absence of evidence to support that in just our atraumatic shoulder pain, but in patients who've had an AC joint injury, then a worsening of scapular dyskinesis seems to correlate with a worsening of symptoms. And if you think of the impact that potentially has, that makes sense. However, one of the other things that I just wanted to share with you, and a thing that I see quite often over those injuries, and because we think instability, we think let's get them moving, let's get the muscle system doing its job, and I'll talk about the key things that I might use to do that, but is actually developing some stiffness. When we look at the compensatory patterns that our patients adopt, if you like, because the shoulder's painful, then there are some kinematic studies to suggest we just shift that axis of rotation. Now, again, in rehab, generally, there's a real move away from kinematic models. We acknowledge there's massive heterogeneity between populations. However, sometimes there are useful things that can just help break that cycle. Now, AC joint stiffness is something that you can see in a lot of different scenarios. I'm sure some of you have seen those patients who've had long-standing cuff-related pain. You've done a great exercise prescription. They do really well, but you just cannot clear end range pain. It can be cuff-related pain or subacromial pain, but you can't get rid of that end range elevation abduction pain. I'm sure you've also seen patients who don't seem to have any stiffness, but they have a block in the coronal plane to abduction. Patients who might have had long head of bicep signs and again have stiffness at end range that you don't seem to be able to clear. Now, for me, I'm always going to try exercise first. And if we look at trying to impact, if you like, clavicular mechanics, because again, our clavicular rotation is secondary to that scapular upward rotation, posterior tilt and protraction, then it kind of makes sense to exaggerate that scapular component. So for me, if I've got somebody that's got a pain and it's at end range, one of the first things I'll do is just get them to do a shrug at the beginning of the movement and see if that makes a difference. If they do that, particularly if you do it in the scapular plane, you're just reinforcing the contribution of those scapular muscles. So just a very quick, easy way of applying symptom modification approaches. I always tend to do that on the background of changing the lever arm. So if they've got pain at end range, I'll change the lever arm. And as I say, do that shrug, see if it makes a difference. If it doesn't, I just add some resistance in at the wrist just to, if you like, bias the posterior cuff, which should be working harder through flexion. And really what I'm looking for is an exercise that just, if you like, gets the whole system working together, but kind of pushes that clavicle round. Now, occasionally, with the best exercise prescription, and that you can see that a simple exercise like that, easy to get the patient doing at home, either with a a physiotherapy behind them and around their wrists, so it gives them that sensory input to the scapula as they're doing that through range, and they can do the shrug. If you do it against the wall and do it like a wall slide, there's some lovely work from Ann Kuhl's group and others that shows that really helps reinforce those scapular rotators and your rotator cuff, but importantly, without getting some of the muscles around the neck that might implicate it. So just doing a simple wall slide with a loop of TheraBand or with it round the back, a shrug, a slide and a shrug just really helps promote those clavicle mechanics. So it's a nice foundation exercise. Another way you can do it is just do a wall squat. So with them against the wall or with a ball behind them. And again, with a loop of TheraBand to remind the cuff to do what it should be doing. And then just do a wall squat around so you've got the scapula almost being given a scapular assistance test by the ball of the wall. So for me, those are great foundation exercises. Now, occasionally, even that isn't enough. And again, in these days where manual therapy gets really bad press, I think we have to be really honest in terms of we don't fully understand the mechanisms of why some of these things work. But I really like in that sort of situation where I'm not being able to clear that end range restriction by just changing what the muscle system's doing, is actually just to do a muscle energy technique or a mobilization with movement targeting the lateral end of clavicle. So again, I just employ the limited things that we know about the muscle system around the shoulder. And I might just get the patient in lying and put my thumb, if you're sat there now, just literally just take your finger. So I've not got the best clothes on tonight. But if you just feel along your clavicle, there's a nice, as you get about 2/3 of the way along, there's a really nice flat bit. Now you can just put your thumb on that lateral part of the clavicle. And if you imagine, if you then externally rotate, you're just reinforcing engagement of the scapula, and you're going to have some sort of effect at that AC joint. Now, again, as I say, for me, if I ever do manual therapy, it's always to feed into an exercise. And I would just repeat that through range. I could just keep the pressure and just get them to do a through range facilitation, more like a mobilization with movement. But the important thing is if it has a therapeutic effect, I then give the patient that to do at home. Now, would I get them doing this themselves? No, because I want them to get into their head. It's the muscles that are making the difference. So I can just put a loop of TheraBand under their foot, over their shoulder, and do exactly what I said with the wall slide to get the same effect. So it kind of gives them the sensory effect of what I was doing in the clinic. Now, as I say, my focus is always to try and get the muscle system working differently. Use that as a basis for my foundation exercises. And I like symptom modification because I think it empowers the patient. It kind of challenges their negative expectations and has a really positive modulating effect on those descending influences. But importantly, it then informs an exercise that's meaningful to them. So while I might see lots of AC joint patients who go out with the same foundation exercises for the patient, they feel that it's relevant to them. And I genuinely believe that's really important. Now, when you've built those foundations and you've got them moving, then again, we just feed into our usual shoulder rehab. However, In that instability cohort, again, there's some really nice work looking at exercises that might give us best value to promote stability around the AC joint. Now, one of my favorites is the archery exercise. And essentially, it's an exercise where I've got my loop of TheraBand, and essentially, I'm just going to pull back and turn my head as I go to that side. So this is my affected arm. So essentially, I just pull all the way back, and I do it on both sides, so I can have an isometric hold or working through range. Now, again, we have to be honest, the EMG literature has some limitations, but what it really seems to do well is target deltoid and trapezius on the background of the cuff and scapula doing their job to enhance stability at the AC joint. Now, we don't want to overthink it, but fundamentally in that position, if you look at the angle of pull of trapezius and deltoid through that deltoid trapezial fascia onto the AC joint, it's a fantastic way of promoting stability. That's a great idea. And then anything in this 90-90 position. So Ben Ashworth talks about doing isometric holds with a chin-up bar in that 90-90 position. I quite like, again, using a band behind a back to really give that sensory input to the scapula. But again, I can load it up and progress it in a way that's functionally relevant for patients. Plyometrics in a 90-90, again, are a great way of promoting stability, but also starting to load up more. But really, what I wanted to share with you is, again, just remember those patients who've had long-standing shoulder pain, some of those athletes we've talked about who had growth plate injuries, who've not been able to mobilize and had some soreness around the AC joint, patients who've had osteolysis, patients who've got some arthritis. The bottom line is, it's certainly in the arthritic population, there is evidence to show if we do more targeted exercise, it does seem to have some preferential outcomes. Sorry, slurring my words. So the reason I just shared that with you is, again, some simple things to just adapt symptom modification to really target that scapular component and promote movement at the AC joint. And if that doesn't work, a really simple manual therapy technique that very easily translates into exercises for the patients to do. And I literally have had a couple of patients recently, a boxer who'd had a 4-year history, very frustrated. Every time he did his boxing, he got soreness, and the bottom line was everything was working all right, but he had some stiffness. I treated him once. I gave him those exercises. We've done 2 sessions. He's back boxing, no problems. Now, do I think it's because of my manual therapy? No, I think it's because I contextualized his pain. I gave him an explanation. He didn't understand why he'd had 4 years of symptoms and not got better with lots of physio and lots of exercises and electrotherapy and goodness knows what else with other people. But the bottom line is, the way in for me to get the best bang for my buck with those exercises was something just reinforced how he should be moving. Again, I had an anaesthetist. I think I've probably shared this story about 18 months ago when we talked about the AC joint before. And this was an anaesthetist who, again, she'd had injections in her shoulder. She got spasms in her neck when she did anything overhead or sustaining positions here. And that, to me, when it's localized pain here and problems in end range elevation, I'm always suspicious about the AC joint. So remember, it doesn't have to be symptomatic to be causing the problem. It could just be stiff. So from my point of view, remember the AC joint refers up into the lateral aspects of the cervical spine in some patients, and it can refer into the anterior axilla. So again, it's just building that picture, end range symptoms, particularly with anything cross adduction, and then remembering that pain distribution. But as I say, we've talked about the key pathologies. I just really wanted to back that up with some key clinical tips and tricks about some things that I find really useful in the clinic with that population. Let's just have a look and see if I can get everybody's questions up. Oh, Louise, evening, Jo. Delighted to be listening. Should have had a shoulder client in, but he came to tell me his shoulder is so much better. He didn't feel he needed a full session, just some advice for progression. All down to employing your management strategies from steps to success. Oh, thank you. That's lovely. Really lovely. We had a great question last week from Dudson about a spiral fracture in a baseball pitcher who was age 25. And at the very end of the Facebook Live last week, Dudson asked, can you get stress fractures in the humerus? And at the time, I said, well, my first thought would always be to rule out any precursors or any risk factors for poor bone health in terms of vitamin D, calcium, obviously any nasty pathology in terms of osteosarcomas, but obviously any other contributing factors. But I thought I must go and do some research, because it doesn't make sense that we couldn't get stress fractures in the humerus. It's just when we talk about our pediatric populations, because the growth plate is the weakest part of the bone, that's where we tend to see these growth plate injuries. So actually the stress fractures are much less common. However, when we look at the humerus, I was thinking more around the epiphysis and around the physial plate proximally. Actually, there is a condition known as thrower's fracture, which occurs generally between the middle and proximal third of the humerus. Now, it's obviously most fractures you associate with significant trauma, but Dudson reported this 25-year-old baseball pitcher playing at a low level, and that's significant, and we'll come back to that, who'd presented with this humeral shaft fracture. Now, interestingly, it is described as a sequelae of a sudden big throw. And so it used to be thought that it was very much on the deceleration phase, and coracobrachialis and deltoid were implicated. But actually, if we think that the fracture happens much lower, then clearly it's not involving the insertions of those muscles. And so now it's thought to be much more related with the wind up, the cocking phase, and if you like, this massive movement of the distal aspect relative to the proximal aspect, and the valgus load that creates in the humerus. Now, there's some quite interesting things that are really relevant for Dudson's athletes and just anybody generally. So there's two key groups. There's one that will come to you and say they had a pop or a crack or a sudden pain in that region of the humerus associated with a sudden throwing action. But they'll also, and this comes back to Dudson's question last week, there's also a population that might report prodromal arm pain, i.e. they've had symptoms in the arm for a period of time, and then they do one thing that just escalates that level of pain. Now, that's suggestive of a stress fracture, but we don't have a lot of studies following people up who get that arm pain and then go on to a fracture. We just have case series of people who report this sudden onset, but then when you question them more closely, say they had some pre-existing arm pain. So who are the people that are at risk? Well, one, there's absolutely no doubt that the thickness of the cortex is inversely proportional to the risk of a fracture. Now, as I said, in terms of age, these injuries are most common in the mid-20s, and there's actually a few case studies that look at people still throwing in their 30s. But the significant thing with these throwers fractures, or as I say, this spiral fracture between the middle and distal third of the humerus, is that it's generally more common in our non-elite athletes, our non-professionals, those who don't throw often. Now, there's a couple of studies that actually showed that if you only threw once a week, so you were doing it recreationally, turning up, playing a match with your mates, but a reasonable level, then actually that represented 76% of people who presented with these fractures. Another case series actually reported at even higher rate that again, if people only threw at any significant rate once a week, again, their risk was much higher. Now, if you think, we've talked about overuse injuries over the last few weeks, and the other common theme is a break in activity. So somebody who plays regularly has a break, and 6 weeks seems to be sufficient to start to get some deterioration or deconditioning of that humerus. It needs that constant load. So again, a break of 6 weeks or more and then going back to throwing seems to be a risk. But the other thing that's really interesting in these days where everybody's really anti-biomechanics and everything else, again, when you look at those non-elite populations and you look at the fluidity, if you like, of force transfer through that system, there is some evidence to suggest that because obviously they don't flow so fluently, their general conditioning doesn't tend to be as good as that elite population, that there's even more load through the humerus, and they don't have as good muscle definition and as good thickening of that cortex in response to throwing as a protective thing. And so again, all those things potentially contribute. So what it would suggest is, in terms of our rehab, obviously we can think about all the things that we can do to target the bone, and a controlled throwing program is clearly an important part of that, but perhaps just optimizing the rest of the kinetic chain to make life easier for the shoulder. But again, it's a really interesting one. The last couple of weeks we've talked a lot about overuse. In this group, it's almost like they haven't done enough preparation thrown then very hard, and so they just haven't had that cortical adaptation to withstand those huge loads all of a sudden. So really, it's a big thank you to Dudson for that question, because it's something I've seen lots of young baseball pitchers. It's a growing sport in the UK, and generally they present with either instability and some long-headed biceps pain, or those growth plate injuries that we've talked about. But obviously Dudson's asked this question about this 25-year-old, and again, I think that's interesting. So a non-elite in their 20s, early 30s population who don't throw regularly but play a sport on a weekly, twice weekly basis, somebody who presents with a pop or a sharp pain that they locate to that region of the humerus, just remain vigilant. Now, if we look at those younger populations, there are a couple of case studies in the literature. There's certainly one in a 21-year-old tennis player who again got it on the wind up of a serve rather than on hitting the ball. Certainly in javelin throwers, softball players, softball slightly heavier than a baseball, sorry. Throwing grenades, whoever did that research, I have no idea. But javelin throwing again is another one. So just something to be aware of. But I think it's really interesting when you look at the case series that are presented, then actually what was a really common theme is that the ones who hadn't had previous pain actually reported a significant pop or snap or some sort of mechanical symptom in conjunction with a sudden big energy throw, and located the pain to that region. So Dudson, thank you so much. Brilliant. Oh, fabulous. Lots of food for thought on rehab. That's brilliant. Because again, I think with throwing, particularly if you've got somebody who throws really hard that isn't doing that consistent work, it does seem to have some implications for morphology of the humerus. So definitely some things to take away. So thank you so much. Tim's here saying awesome stuff. When we look at instability per se, I'm sure many of you are aware that in the shoulder, we have traumatic, atraumatic, and atraumatic, our muscle partners, our lax people, whatever. We can get similar presentations in the sternoclavicular joint, in the atraumatic, and often relate to muscle patterning. But in the AC joint, there's only 6 cases described in the literature. So in terms of muscle patterning or AC joint instability, it's incredibly rare in the AC joint. Simple modifications made amazing change on my patient's outcome faster since attending. Oh, well, this is lovely. Thank you, guys. This is a very nice evening. Fantastic. Lots of very nice comments. Thank you, guys. That's really super. But really, for me, this is all about sharing practice. Your questions have been fantastic. Think of Dudson's. That really made me go away and look at the literature, and make me vigilant about something that I actually haven't seen in my practice, but it followed on beautifully for those other things that we talked about. I'm intending to be back next week with another interesting case study that's particularly relevant in terms of COVID at the moment, and just something to be aware of, but also an opportunity to reflect on the literature and perhaps what gives us best value in a potentially difficult situation in terms of promoting patients' recovery. I really hope you've taken some useful clinical tips away tonight. I'm very conscious that a lot of the Facebook Lives, we've talked about interesting case studies, and my reason for doing that is because we could argue there's a bit of a shift away from a biomedical model. But, at the end of the day, we still need to be vigilant about these things and know that when rehab is the option, it really is the option. And so that's why I like to share some different or difficult cases that I've certainly learned from, but importantly to share with you. But as I say, hopefully you've also taken some clinical gold away tonight with the things that I find really useful in my practice, particularly with that AC joint population. So guys, I said I was going to go. I promise I'm really going to go now. Thanks as ever for joining. I'll very much look forward to seeing you next Monday. Thanks so much.